So if I can explain how to use this. So this is my method of operation. So usually I go in the mountains, climbing and hiking, and develop my models. But eventually work is much harder. But this is something which government thinks of what I'm doing. Let's say. So bladder cancer is very interesting because it's not hereditary. It's something which could be occurred due to the occupational exposure to chemicals, and smoking is the main factor for bladder cancer. So it's the most common, the second most common cancer for smokers. Another famous group of bladder cancer are artists, painters, and sculptors. So most of them who die in the old age, they usually die from bladder cancer due to the exposure to pain and other materials. So it's bladder cancer is also considered cancer of developing wall. It's a very long process until it develops, and that's why most cases belong to people over 65 years old, so which are, according to the life expectancy, mostly living in the countries with high level, in developed countries. So, despite resection of tumor, about 70% of patients experience recurrence. So this is one of the major things with bladder cancer. So it's not probably, most probably it's not the mortal one, but it's the most recurrent one of the most recurrent. So there is no well-established bladder cancer therapy, and there are very, very few treatment strategies, and all of them, with no exception, have harmful side effects. So one of the things which is our final goal is to develop some, or to optimize a therapy which could slow down or stop tumor development and growth. So some statistics that it's 7th most common cancer worldwide, and it's more than 50,000 men and 16,000 women are diagnosed with it each year. So it's something which if it's very common, so it means that we also have access to a large amount of data, something which we really can base our research on. So this is one of the positive things of this type of cancer, and because it's developing for a long time, so there are long process, lots of observations, and there are a lot of information which could be used for this purpose. So now let's look on the human bladder, so which is consists of the number of layers, and very important that there is a very layer. This is a blood lumen. This is a lamina propria where the blood vessels are located in a muscle, outer muscle. But the interesting thing is that this is a transitional epithelium, is a transitional epithelium, and this is where the tumors usually start from. And in fact, vast majority of human tumors are start in transitional tissues, epithelial tissues. So this is the most common tissue for this purpose. And there are no blood vessels in transitional tissues. So when there is a when there is a blood in the urine or somewhere detected in transitional tissues, means that not only that the cancer tumor has started, also it means that there is some way of angiogenesis. So the only way blood vessels could penetrate or could go through epithelium is due to angiogenesis. So this is a epithelium which we are now trying to dissect with different layers. So then we have a bladder wall where usually carcinogens are accumulating. We have umbrella cells, which are the largest cells, some of the largest cells in the human body, maybe the largest one. So they work as a protective barrier, and eventually after this there's another barrier which consists of intermediate cells. And what they protect are, first of all, they protect basal cells, which are in fact stem cells, which used to replace cells within the epithelium. They also protect underlying tissues. So these cells are, in fact, this is the main barrier for urine. And this cells, when these cells are getting dying or getting killed, so they're replaced by the cells from the due to division cells from the basal level, and these cells, the basal or stem cells, they can mutate, and if there is inflammation or if there is some process which requires large scale repair of orthelium or other cells, so they can also yield the cancerous phenotype. And that's one of the best, one of the most interesting definitions of cancer. So cancer is a killing process which went out of control. So this is something which happens when basal cells start to repair orthelium, they start to divide, and they eventually bring the mutations and all cells with cancerous phenotype everywhere within the orthelium. So so the orthelium, the diameter of the cells varies. So from the 5 to 10 microns to up to 200 microns, which are larger cells in the human body, and this is umbrella cells. So this is a just location where usually the kidneys, bladder, and this comes outside. There are different stages of bladder cancer. So the ecological grades and the staging. So this is so it varies from carcinoma in situ, which is usually goes undetected, TA and T1, which is just a bladder polyp, which is the most common type of bladder cancer, and it goes up to T4, which is a cancer which invaded. So the most complicated invasive form of bladder cancer, which usually requires removal of blood. So approximately 90% of bladder cancer cases are transitional cases. So carcinoma, and then there are superficial bladder cancer, which is about 75% of bladder cancer, and invasive bladder cancer, which is remaining 25%. So this is more or less division, and most of my talk I will dedicate to this type of cancer because this is not common, and this is something which is usually could be treated with some type of therapy. So usually the gold standard for diagnosing bladder cancer is a biopsy, which is itself very painful procedure. So now let's go to biological, physical explanation of what's going on, and start to put it to the sum of macrophage. So first the carcinogens are accumulating on the bladder wall, getting mixed within some solute, and slowly penetrate through the orthelium. So when the carcinogen concentration inside the basal cell passes certain threshold, the cell starts to mutate. So there is no fixed value for threshold, but for some there's a lot of experimental information which can more or less say that which carcinogen concentration could lead to some certain type of mutation. Especially, it's everything what we do, or all numbers which we use, are based on the real experimental data which was taken from the people who developed bladder cancer who were smokers, who were multiple smokers. So it was all the information was determined. So this information we consider as information we can use for our test. So usually there is a sequence of 4 or 5 specific mutations which could provide basal cell with the cancer phenotype. So the mutations are, there is also importance in the order of mutation, but we're not talking about it, but it's usually some special types of mutation which always detected in the bladder cancer. So they consider it a bladder cancer specific. So some of them are general for cancer, like suppression of P53, but there are some specific for bladder cancer, and they detected in most cases. So there is one more thing: the tumor cannot grow beyond a very, very small size, about 1 to 2 cubic millimeters, due to the lack of oxygen and other essential nutrients. So this, in this case, the cancer cells or clones of cancer cells will send signals to the blood vessel, to the lamina propria where the blood vessels are located, and this starts a process which we know as angiogenesis. cancer cells are much more resistant to hypoxia. In fact, they have when a regular cell will die, the cancer cell will just go to the so-called sleeping state. It will wait until it has enough oxygen, and only if it survives for a very, very long time, it will eventually die. So to kill cancer cells with this type of therapy, or with just reducing their access to nutrients and oxygen, it usually doesn't work, because they can just survive in this condition. So proliferation rate of cancer cells high compared to their normal cells. So they have apoptosis gene suppressed, and they can proliferate infinite number of times. And the regular cells, after some certain number of proliferation, they still live, but they already stop proliferating, and eventually they die. So they have finite number of proliferation. So cancer cells usually can change layers of occupation during the proliferation state, and normal cells, except basal cells which could take their phenotype and replace them, they always remain on the same layer. So Bladder has a very strict layer, multi-layer system. Again, it's the same, operates to all other types of epithelial tissues, and epithelium is a source of most or vast majority of cancer. So now mathematical framework is a cellular automata, which is a discrete model, which in fact is a dynamical system, and submodels of so we have, this is our framework, major framework, which is cellular automata, and we have models which continuous models represented by finite by partial differential equations. So one of them represents oxygen diffusion model, oxygen and nutrient diffusion, and another one represents gene penetration. So we have two models which run between the cellular automata update stages, and we update these models so they communicate with each other through cellular automata framework, and they communicate with cellular automata algorithm, and we update them on every step. So on every step, and we also involve here angiogenesis. So we have a submodel which is also described as cellular automata for angiogenesis, and it's used to update, to communicate with oxygen diffusion model in order to update the oxygen concentration in the cells. So this is a general framework. So we have a model of angiogenesis, and there is one more model which I'm not reporting here, but I was talking about this most continuous submodel when I was in South Africa. It's a model of tumor invasion. So invasive model is a submodel of this person, I was talking about it 2 years ago. So now cell living cycle. So this is a something which we model with cellular automata. So we represent each cell with an array of elements, which in fact are, the cell automata is represented by the array of elements which identified with the real cells, and they have a state vector which defines their position, it defines their occupation status, it defines oxygen and nutrient concentration and concentration of nutrients, which correspond to the continuous models of diffusion and penetration, and it's also mutation status. So we can also have also mutation counter, which can give us information if the cells already obtained cancer phenotype or not. So now, model of angiogenesis is the cellular automata model. So the cell sends signal to the vascular network, and as soon as the cell does not have sufficient amount of nutrients and oxygen, and as soon as the signal reaches the closest cell in the foramina propria, the blood vessels start to branch away, and it works as a source of oxygen and nutrients for all surrounding cells, including cancer cells, but also for the rest of the epithelium. And we also take into account that the cells have high permeability, so they behave differently from the regular. They have different physical properties, different from the regular blood vessels, from regular blood cells. So on each step we consider that the blood vessel grows one cell, and what's interesting is that this angiogenic, angiogenic sprout, the tip of the angiogenic sprout, they secrete some enzymes which kill the surrounding cells. So the angiogenic tree grows not only grows by towards the tumor cells by opening its way. So they kill cells in the epithelium which lie on their path. So and one reason is that this usually the tip of angiogenic sprout is not something constant. So the cells, different cells could be there, and they change their location, and they then secrete these enzymes. So it's process multiple cancer cells which experience lack of oxygen sends a signal, and after some time it could reach or laminopropria or existing existing branches of angiogenic tree, and eventually we get some very complicated mesh structure, which is known as cancer angiogenesis, and it was also described in more detail by so now we go to continuous processes. So here we use diffusion absorption equation, which is when we change the coefficient with variable coefficients, which are depending on cell status of the parameters of the cells which we get from the cell automata model, and after that we supply the results of this model to the result of the continuous model to the cell automata, so we can update the cell status corresponding. So at each, and as I already told, that we have the number of thresholds. Again, they are not strict, but they approximate, and we know that their values are correspond to the actual changes in the cell behavior. So, and we address epithelium in fact as on the macro level as multi-layer porous medium. So this is our approach to epithelium. So we use this framework, and this is a form of diffusion absorption or diffusion reaction equation. Diffusion absorption impact. So we have a diffusion, we have absorption. So the diffusion, one can say that what we consider as porous medium, it's a porous medium type equation, which has first of all it has non-negative solution. So we always can control the solution, and due to non-linearity, we can also control the speed of diffusion. So we know that the penetration process, for instance, is very, very slow. So we can control it by fixing parameter here. And we also, the question is non-linear, so we don't have the problem which is common for linear models. So in our field, we have finite speed of diffusion. So
what is your variable you are? I mean, the main variable of the.
So the main variable here is U, which is a concentration of carcinogen, which is we compare to the threshold, or concentration of oxygen and nutrients, which we also compare to the threshold. So this is our main variable. So we know concentration of this quantities within the epithelium all time. So that's something we do. So and also it's also for this, because this is continuous process, so it has their own temporal scale. So for instance, if we consider the cellular automata resolution could be 1 month, so here the resolution could be up to 2 seconds. So we get here, the resolution here is much more fine than the resolution of the cellular automata system. So from good mathematical point, we can also show that the system has, so we can prove that the system has unique existence. So there's existence and uniqueness of solution. So using variable solution exposed in the equation, so we can do some transformer variables and process something which is some assumptions. So we consider that we ignore geometry of the cell, and the only thing that we do take into account is the relative size of the cells. We have, if cellular automata uses single cell as its grid point, for diffusion, for carcinogenic integration, and for oxygen diffusion, we use a grid which is comprehended with our numerical simulation stability and resolution. So we also consider that carcinogenic concentration inside the living cell is not increasing, and cell death, both necrosis, leads to the empty space with no carcinogen. But when cell dies, so its cell removed from the dead cell removed such a way that they don't leave, usually they don't leave any waste when they disappear. So this is a process which is known. So how the space is clean, so we can have, so it's a very realistic assumption. Also consider that the newly born cell has no carcinogenic concentration, but they keep the mutation counter of the mother cell. And we also said that carcinogenic penetration stopped, or in fact, very significantly slowed down by the basement membrane. So the carcinogen doesn't reach the tissues below the organ. So we also know, or some of the most of the parameters we find in the literature. Few we estimate, but we know that the diffusion and absorption coefficients of different types of cells and mutation thresholds for at least some carcinogens we could find in the literature. So this is something. So all our models are based on the realistic parameters. So now this is a picture. So this is a view of our two-dimensional. We consider two-dimensional slice of the rotarium, one cell thickness, and this is our model. So we have Bladder lumen. This is the umbrella and intermediate cells. This is the basal layer. This is where we have blood vessels, and here just around the tissues we use to model invasive type of bladder cancer. And this is a real picture which looks, I would not say that it's very similar, but it represents exactly the same structure. So we have bladder cavity. We have regular rotarial cells, which are umbrella and normal cells. We have basal cells, which are significantly smaller than regular rotarial cells. And we have lamina propria and below. So now this is just a step of our numerical algorithm. So we have, so we divide the layers to give them different structure. So we update each step on 1 month, so which corresponds to, let's say, virtual microscope when we get 1 month of observations. So this is what our cell automata would be compared to. And after each new cell enters interface state, after its birth, during this state, the cell grows in volume and it replicates DNA, and the cell death in orotarium initiates the signal for proliferation for basal cell, and if the cell is in proliferative state, it will divide to form 2 daughter cells. Each one will replace or renew the dead cell, and another one will renew this cell, and another one will move to the empty side and replace the cell which died, and it will eventually accept the phenotype of the dead cells. And it's interesting that the orotarial or basal cells, they are the smallest cells, but they're the smartest ones. So they can accept the phenotype of any other cell, and the phenotype of the cells which are lying intermediate or umbrella layer, they have very, very few functions, and eventually what they do, they just protect. They don't do anything else. So the daughter cells again inherit the mutation counter from the mother cells, but not its carcinogenic concentration. And during the cell turnover, so all the differentiation cells are eliminated by the division progeny of stem cells, and the rotarium has one of the lowest turnover rates numerical simulations will involve no black boundary conditions, and we consider the diffusion coefficients are constant for each type of cells, but the type of cells will change during the simulation. And we consider that the initial distribution of carcinogens is random along the bladder wall. And for our simulations, we use just force-directed Runge Kappa scheme for integration in time, and force-ordered implicit finite difference scheme for integration in space. So this is just the scheme we are using. So this is some simulations. So here you can see this is a type of, this is a real picture. This is what we do. So you can see and angiogenic tree, and interestingly, thing about the angiogenesis which we see here, and which is also corresponds to experimental results, that when so eventually angiogenic sprouts, they go within the polyp and they destroy in fact all outside within the bladder fluid. They not surround the polyp but go inside and destroy all cancer cells. So this is something which is specific for bladder polyps. So this is a carcinoma in situ, which is usually remains as some kind of mushroom type shape, and this type of cancer is usually rarely detected, and it's one of the most dangerous type of cancer. So it's I would say that it's not as harmful, but again it's not grow as polyp. It's usually stop in on this stage, but carcinoma in situ with very, very simple mutations, with very common mutations, could in fact become very, very dangerous invasive cancer. So this is one of the things about carcinoma in situ. It's rarely detected. It's usually it's usually kept without any treatment, but it could be easily give start to the very harmful, invasive bladder cancer. So this is just a very, very simple and single mutation which would lead to this change. So now I will go to the last part of my talk about, and I will talk about the treatment. So now we have a framework which gives us cancer, which gives us model cancer or tumor growth and development and growth. So there is the different types of treatment. So one is section, one is chemotherapy, and this is the most interesting type of treatment, which eventually was first experimentally, or first off in late 20s, when one of the medical doctors was treating tuberculosis, just saw that this treatment was also working for people with bladder cancer, and he published his results, but he published in the wrong, as usually in the wrong paper. It was, I would say, it was rediscovered. This research was rediscovered by Moraes and published again in 1976. And what happens is that eventually the same therapy, which is used for tuberculosis, it's now the main therapy which is used for main treatment for cancer, for bladder cancer. So it has its own. So this is a BCG. Again, I just mentioned this is a bacteria which are used for treatment of. It's a weak form of tuberculosis which is used for its prevention, but it's also used for treatment of bladder cancer. What it does, so it's eventually the goal of this bacteria is to reactivate immune system, and this will lead to the activity, to the anti-tumor activity. So this is what's the idea behind this therapy. So this is how it works. So we have there are BCG injected into the bladder, and eventually it leads to the cell death, and some of the cells are cancer cells, and some of them are regular cells. So it has also some harmful effect because it kills eventually not only tumor cells, but all the cells it would find on its way. But in addition to this, it activates the immune system, which in its turn works again or kills eventually only tumor cells. And it's also based on the convention, I will talk about it a bit later, that after the surgery, this therapy, it's done always after the surgery. So how? We have 2-3 minutes. Okay. So this is what. So it's done after the surgery, and it's used in the most cancer cells, remaining cancer cells, non-eradicated cancer cells, allocated close to the place where tumor was or polyp was formed. So the common protocol involves usually weekly instillations of BCG over 6 weeks period. So this is a standard scheme. So problems, there are side effects. So there are 3 types of side effects with the BCG treatment. All of them are very, very harmful. And BCG is effective in about 50-70% of patients. So it means that for bladder cancer, there is very effective, compared to other types of cancer, there is a very effective treatment for bladder cancer. The problem with the remaining 50-30%, I will talk about it a bit later. There is a very serious problem for these cases where BCG doesn't work. And this is one of the open issues in literature. So again, when we built our BCG models, for our hope, and it's hope of medical doctors and of urologists, that the remaining cancer cells are located close to the removed part of the urothelium. So when the BCG bacteria are injected into the urothelium, so they can kill or eradicate most of the remaining cells. So we use also cellular tomato model, which is discrete dynamical system, to study this, to model BCG. So BCG injected into the bladder, they infect and kill cells, all the cells they need on the way towards the basement membrane, and they also activate the immune system, which kills hopefully all remaining cancer cells. So BCG itself has again, it kills a lot, but it has a very short lifespan, so they die themselves after a few days. So the main concern with BCG is that surgery, BCG, and activated immune system, they kill all of them, kill millions of cells. This yields very intensive stem cell proliferation and fast repair of urothelium. Usually urothelium is repaired after a few weeks. It's already all the cells, all the dead cells are replaced. The problem is due to the small base of the substitution, especially when the large part of urothelium is removed, there are somatic mutations accurate rate much greater than the normal rate of mutation. It's called so-called hypermutation. And the newly born cells may obtain a phenotype, and this is what happens in 30-50 cases when it doesn't help. So this is the main issue. So they have a phenotype which is resistant to any convenient therapy. So if BCG doesn't work, so probably nothing else will work. So this is a main problem with BCG, in addition to some other factors. Okay. So if it doesn't work, so there is probably no therapy which will work. So now what we did here, so this is in fact this result was this is analysis which was inspired by the paper which I reviewed. So when some French scientists, they killed a few hundred mice, but what they did was it was for purpose. They studied growth of the experimental. They did check experimental growth of different types of tumor, and they wanted to look on the basic mathematical models of tumor growth. So they just were comparing the results and predicting results to some basic ODE-based models, which could be useful for this purpose, for the volume, to estimate the volume of tumor growth. What they found that only breast cancer was the cancer which could be considered, which could in fact be described some proper mathematical models. For all other types of cancer, all standard simple mathematical models were found there. So this is examples of were just examples of type of treatment. So there, when we see it works, so in this case the tumor continue to grow, but it goes to some steady state and never grows again. This is when it just slows and grows more or less linearly. And this is when, after the surgery, in many cases, people just not go for treatment. And so there is a growth, there is a long period of some still or almost no growth, and eventually start to grow exponentially again. So this is two examples. So here we can see this is an example of what happens after the surgery. So this is where part of tumor which were removed, this is part of the tumor which remained, and eventually they will start growing. So this is what we see after the immunotherapy. So this is the black this bacteria. So you can see that the tumor, remaining part of the tumor, is started to grow, but eventually the growth was stopped, and we waited for a very long time, and eventually they never went away from this. So now there are lots of open problems, and one of them is therapy adjustment, optimization of therapy strategies, and eventually the main goal for clinicians is to predict conditions for which ECG cannot help, and to improve and to go to the mechanism-based combinations, which can probably improve the success of ECG with chemotherapy and some other types of therapy, and radiotherapy. And finally, they want to go to individual modeling, which is the goal of any research, so they can predict from using our models and their own estimation how to treat any patient. So I want also to thank my colleague Ivana for introducing